respected chairpersons, organizers, and delegates. Dengue has been a major issue in tropical countries in spite of advancement in the management of this condition, in spite of good guidelines from the WHO and government issued guidelines. Partly because these guidelines are not based on randomized control trials, and so they are not evidence-based, but they are based mainly on expert opinion. But this expert opinion was based on the understanding of the pathophysiological sequence of dengue infection. The management of severe dengue probably has gone through various phases. Initially, the word hemorrhagic fever caught the imagination of the treating physicians, and the main focus was on platelets and bleeding tendencies. Unfortunately, that emphasis still continues. Later, and rightly, the focus was shifting to the capillary leak that was a major component of the pathophysiology, and most of the guidelines are emphasizing on appropriate fluid resuscitation for patients with dengue. But of late, we also know that there is another phase of pathophysiology coming up now in the form of inflammatory changes, which is seen in most of the infectious diseases. 3 or 4 components have been discussed today, which are very relevant for my presentation. Dr. Krish mentioned the microcirculatory changes that occur in sepsis conditions. That is very relevant for severe dengue. Dr. Ranjan talked about biomarkers and the way they can identify early disease and early pathophysiology. That is also very relevant for the discussion today. And Dr. Srinivas pointed out the reactive nature and the necessity for the proactive nature. We need to be proactive in our selection of our tools so that we can prevent the complication happening instead of just reacting to the complications that have already occurred. And finally, Dr. Ashish Hegde emphasized the importance of subgroup identification. When we say steroids are not useful in dengue, we are talking about the entire population of dengue patients. But if we are able to identify a subgroup of patients, if we are able to identify them by clinico-physiological mechanisms, maybe there is a role for steroid in that particular group. So these are the 4 points which are going to be relevant for my presentation today. Now, with the newer knowledge of inflammation coming up in most of the cases, including severe dengue, there is a need for reviewing the present guidelines. The traditional nomenclature of hemorrhagic fever has been a major focus for defocusing our approach. This nomenclature misled us to focusing on platelets because of the word hemorrhagic fever. And WHO rightly understood this problem and changed the nomenclature in 2009, classifying dengue into severe and non-severe dengue, the non-severe dengue being dengue and dengue with warning symptoms. So the severe dengue category was dengue shock syndrome and also with organ involvement. For the first time, organ involvement came into diagnostic classification of dengue patients, and probably that was the point when we started looking into the organ involvement due to causes other than capillary leak. And that's where the cytokine-induced inflammation, cytokine storm, otherwise called as HLH pathology, came up into the limelight for dengue infection also. This is a busy slide. The purpose is not to go through the slide, but just to highlight the fact that the classification has changed. What is defined as a severe dengue includes the conventional dengue hemorrhagic fever with shock, and also many conditions called as expanded dengue syndrome, which simply means that dengue with organ involvement. Otherwise, with the conventional explanation of capillary leak and hypotension alone, we could not explain many of the organ involvements. So that was understood and has been included in the expanded dengue syndrome, which is a category under severe dengue, and that's one condition which will explain a lot of ununderstood complications of dengue infection. Till now, we have been looking into the severe dengue complications as a combination of vasculopathy and coagulopathy. We know that there is vasculopathy, wherein there is, by the end of about 3 or 4 days, there is increased leak into the tissues at the endothelial level. That vasculopathy coupled with coagulopathy was highlighted for a long, long time. Now what we know is that in addition to that, there are two other additional components, that is cytokine storm and also secondary infections. All four of them together lead to the complication of severe dengue. So when we treat patients, we should keep all these four in our mind. These clinical and pathophysiological approaches should be kept in our mind so that the treatment can be quite comprehensive. This is the classical explanation of the pathophysiological events in dengue. There are three phases: initial viremic phase, febrile phase, followed by critical phase when a lot of changes are happening, and then recovery phase. The critical phase starts after about 4 or 5 days when NS1 becomes negative. So it is not because of the direct viral involvement, it is probably immune related. By the time the capillary leak is happening, the NS1 is almost becoming negative. So it is probably not a direct viral involvement, it is a host response which leads to the capillary leak somewhere around the 4th or 5th day, and that leads to the significant capillary leak. And from this point onwards, either the patient recovers and gets into recovery phase or succumbs to the illness. So the critical phase wherein there is capillary leak and other associated conditions is a phase where we should be very careful. And what we know now is that this additional component of cytokine-induced inflammation starts by around 3rd or 4th day, peaks by about 5th or 6th day, and then slowly comes down. But then if you are able to identify the cytokine storm quite early in the disease process, maybe we can offer good cure to the patients. And it is very important for all of us to look into this cytokine storm. So far, we have been unnecessarily focusing on the platelets, a study which compared various factors in those who succumbed to dengue and those who survived dengue, found out that the mean platelet count was higher in those who succumbed to the disease than those who survived the disease, clearly suggesting that platelet is not a point in pathogenesis at all. Hence, we should stop worrying about platelets and look into many other important pathophysiological mechanisms. Similarly, platelet transfusion also is found to be of no use. A prophylactic platelet transfusion has no role, as seen in this graph, where both lines are going together. Only when there is significant bleed, platelet transfusions are required. And the guidelines are focused clearly on fluids. The amount of fluid depends upon the condition of the patient, and close monitoring is required of the crystalloids. There has to be very close monitoring because the things can change very rapidly in dengue infection. It's a very dynamic situation. Once the capillary leak starts, next 24 to 48 hours, whole thing will be changing rapidly. There could be increased requirement, or the requirement can come down suddenly, in which case there needs a very aggressive de-escalation also. So it's a very dynamic situation of fluid requirement. And when the shock persists in spite of rapid crystalloid solution, that's the time when you must consider other causes, maybe inflammatory causes, maybe secondary sepsis, or the need for colloids, or the need for vasopressors. And if there is DIC, then fresh frozen plasma may be required. I told you earlier that there is a very dynamic change. Unlike other conditions, please note that within 24 hours, the requirement, which was about 20 ml per kg per hour, can rapidly come down to 1.5 ml per kg per hour. So those who are managing severe dengue should be keeping a very close watch on the patients. And this capillary leak syndrome is a very transient phenomenon. It's more of a functional change than a structural change, unlike sepsis. And hence, needs to be a very close monitoring of the patient. And if the pathogenesis continues for more than about 48 hours, that's the time you must look for alternate causes. A simple capillary leak syndrome does not generally go beyond 48 hours, 24 to 48 hours. And by that time, there's a rapid reduction in the requirement of the fluids. What was 20 ml per kg can come down very rapidly. And hence, if the fluid requirement or if the condition does not improve by about 24 to 48 hours, please look for alternative causes like sepsis or cytokine storm. And while managing this patient, the fluids, if the hematocrit is increasing and hemodynamics are worsening, increase the fluids or add colloids. If the hematocrit is decreasing but hemodynamics are worsening, give blood and blood products. If the hematocrit is decreasing and patient is improving, reduce the fluids rapidly. Secondary infections were seen in good number of patients with severe dengue. Almost 60% of the patients with the severe dengue had secondary infection. So timely recognition and appropriate antibiotics are required. So when there is organ failure beyond volume correction, you must consider well-established shock which is giving rise to organ damage, or secondary sepsis, DIC, or a cytokine storm. That is HLH. HLH was a syndrome which was identified a long time ago as a primary condition due to hereditary causes. But now we know that Large number of acquired infection also can give rise to similar syndrome called as secondary or sepsis-associated HLH. And HLH is not a separate disease. It is just a clinical condition due to another condition like a severe dengue. Its body has delicate balance of all these events: coagulation, anticoagulation, osteoblasts and osteoclasts, inflammation, anti-inflammation, mitotic and apoptotic, or inflammation can be either protective or pathologic. So there is a delicate balance between the two, and often one condition gradually slips out the other, and it is very important to identify the change from a protective to pathologic event. That's where looking for an appropriate cytokine marker is important. In normal phase of inflammation, there is inflammation, but the normal immune system is activated, then comes down to the quiescent level within a short period of time. But if it goes uncontrolled, that's what is called as HLH. That you may either use the word HLH or HLH-like syndrome or a cytokine storm, but ultimately it is the uncontrolled cytokine that is the underlying cause. Can be diagnosed either by classical 2004 criteria for HLH or H-score based on the online calculators. You can use either of them for whichever is convenient for you. And when we have a patient cytokine storm, while treating it, we have to understand that we may have tools, but the timing is important. And you must also identify what is the trigger and what's the target. There's no point in chasing the target because the damage is already done. What we need to see is what is the trigger and control the trigger. And one of the markers of a trigger is soluble CD25. And that is the only cytokine, that's why I said it's trigger in HLH criteria of 2004. All the rest, for example, ferritin, cytopenia, organomegaly, all of them reflect the established end organ damage that is the target. So if there could be a marker of a trigger in the form of soluble CD25, that probably is better biomarker. As seen in this graph, the rise in CD25 occurs much earlier than other markers like ferritin. Traditionally, ferritin has been established biomarker for HLH, but in dengue infection, probably soluble CD25 is better than ferritin. And we did a small study of 80 dengue patients and found that the correlation coefficient for soluble CD25 was excellent with H-score of 0.98 compared to only 0.51 for ferritin. And what's more, sensitivity and specificity of soluble CD25 was nearly 100%, and we have published this paper recently wherein we found that soluble CD25 had a very high sensitivity and specificity for identifying dengue HLH patients diagnosed by H-score. So soluble CD25 could identify a subgroup of dengue patients who might benefit from immunosuppression, and because soluble CD25 is an early and effective biomarker. So from a broad group of dengue patients, you can identify a subgroup which may respond to immunosuppression, and that soluble CD25 can be measured easily by ELISA method like ferritin. And once we know that there is HLH syndrome, we need to be aggressive with the immunosuppression. High-dose steroid has been tried. Most of the treatment for dengue HLH is only observation study. We don't have randomized control study. And this study found that with 1 gram of solimedrol, there was a reduction in mortality. IVIG, 19 patients were given, all of them survived, but all of them are observational studies only. So when do you suspect HLH-like syndrome? If the fever is persisting more than 7 days, if there's prolonged cytopenia or organomegaly, and if there are sterile cultures, and if the biomarkers like soluble CD25 are elevated, that's when you must suspect HLH syndrome and be aggressive with their treatment. How do you differentiate vasculopathy from cytokine inflammation? Fever more than 5 days. Hypovolemia is profound in vasculopathy, not so much in cytokine inflammatory syndrome. Hemoconcentration is a feature of vasculopathy, but not cytokine inflammation. And significant thrombocytopenia, significant neutropenia is a feature of cytokine inflammation. More importantly, splenomegaly is a feature which will identify a cytokine syndrome than vasculopathy. And soluble CD25 will be very high in a cytokine syndrome. And steroid may have a role in cytokine inflammation, but not simple vasculopathy. So if there is a dengue patient, watch for warning signs and symptoms and look for markers of inflammation. If there is vasculopathy, clinically and laboratory-wise, treat them with a good amount of fluids, and if there is no response, add crystalloids. If there is cytokine storm, as evidenced by prolonged fever, give them solimedrol or immunoglobulin or other immunosuppressives. If there is secondary sepsis, treat them with appropriate antibiotics. Thank you very much.